medical educators are thinking a lot through how do we make sure that once AI tools are used, that we don't lose these skills.
I've been thinking a bit about AI in medical education, and actually medical education in terms, I think, of both educating and learn. I use AI to do research, right? And then I try to accept, or I get the results. Sometimes I believe it, sometimes I don't. Sometimes I go double check it. There's been a fair amount of discussion lately about people just believing the AI, no matter what it says, and not going to validate it. It's kind of cognitive laziness. There's a whole thing about AI psychosis, where because people have convinced themselves that the AI is telling them the truth, and it tells them things that are completely untrue about themselves. Are we going to get to a place where we can trust the generative AI with the basic education or learning that you need to go through as a physician? That's what I think of, like medical education. How am I learning from the AI? Is it summarizing things correctly? Is that an area where this will also work outside of the hospital environment?
Yeah, I mean, one of my roles at UCSF is I'm also the faculty lead for AI innovations in medical education for the School of Medicine. And these are some of the very things that the very questions we're struggling with ourselves. There are some, kind of low stakes use cases for AI in medical education and some higher stakes ones. So some of the lower stakes ones, again, not super sexy, but here's an example. Medical students, residents, they have historically needed to keep some kind of logs of the types of cases they've seen or the procedures they've done. It used to be you'd keep literally a paper log. I just did procedure X and I got here's the date I did it. And, that eventually moved to some other electronic platform, but you'd still have to go and type it out. And so, people are, especially when they're training and in practice, there's not a whole lot of time to go and sit down and type those things out. And so the question is, can we just use AI, generative AI, to read through the chart and say, okay, this procedure was done, and it creates the log or the case mix log to make sure that the students are getting the appropriate exposures and training they need. That's pretty low stakes, not super exciting. But I will say there are all kinds of other use cases, both in learning for medical students before they start seeing patients, like in the first 2 years or so of medical school, and in their last couple of years when they're seeing patients. And I will say whether we like it or not, the students are leading us where the future is going to be. They are all already using AI in some way. And so it really becomes incumbent upon us as the educators to figure out how do we put some reasonable safeguards in place and guardrails and make sure that they're using these things in responsible ways. One of the interesting use cases that's somewhat administrative but is also helpful for teaching is to try to figure out from like notes, let's say a medical student has written, and ascertain, can we determine what their clinical reasoning process is? Now, historically, that would be very time intensive. You'd have an attending physician look over the note that a student wrote and then sit down with them and say, okay, from this note, here's what it looks like your clinical reasoning is, and here's some of the opportunities, some of the challenges. But could we have AI do that assessment on each and every note and then maybe generate what we call tutor bots? So like an AI generated case to help with certain areas that were weaknesses, to help teach that learner in a scalable way. And so those types of things are also coming too. But what I will say, and this is an area of particular interest and concern, is this thing called de-skilling. And so what I mean by that is, I don't know if the last time you drove in a car that did not have a backup camera, but if your car has a backup camera, you probably have gotten used to it starting to beep loudly at you if you're about to back up and hit something. And then if you've been doing that for years and you get into a car without a backup camera, you might just back up and wait for the beeps and not realize those beeps aren't going to come. You have been de-skilled in your backup skills. And so the question is, if learners are relying on AI to do things for them, are they going to de-skill, or might they be never skill in the first place? And there was a study that came out just like a week ago about the use of videography-assisted AI in colonoscopies, with gastrointestinal physicians who have been doing colonoscopies for years, having 3 months of usage of AI-assisted colonoscopy, where on the screen the AI is detecting polyps. And after 3 months of using AI, they were then exposed to either not AI or with AI colonoscopies. And it found that these physicians who have been doing this for decades de-skilled. They had become so reliant on the AI that when they were not using the AI-assisted colonoscopy, they were detecting fewer polyps than when they were using it. So it's a real concern, and medical educators are thinking a lot through how do we make sure that not only the skills developed in the first place, but that once AI tools are used, that we don't lose these skills.
It's interesting. I actually spent some time talking to a company in that very specific space of using imaging for assisting with colonoscopies. And they were showing me how basically on the video screen, it would highlight what was the polyp and it would tell you whether it was cancer or not. It had a whole bunch of metrics on the back end. And a big part of the value proposition and argument is like, the first colonoscopy of the day when you're feeling fresh and you had your coffee in the morning is a lot better than the last colonoscopy of the day when you're tired and you want to just go home, and that this would introduce new standards and a better and higher standard throughout the process. And based on what you're saying, it sounds like the people who are taking advantage of that text may actually be de-skilling themselves. So it makes me wonder, is that a bad thing or a good? Like, how do we judge that, right? If it's better with AI, but that makes the humans a little bit less good, but it's still better with AI, is that still okay? Or is it bad that the humans got less good at what they were doing in the first place because they got the assist?
Well, let me ask you this. Like, if you were to get on an airplane and there's AI somehow assisting the pilot and now it makes travel safer, but let's say the systems go down. Do you want your pilot de-skilled? So, I'd say the same thing like in medicine. These are sometimes life and death type of activities and decisions. And so maintaining skills, establishing them in the first place and maintaining them, I would argue, is probably super important, even though when everything is going right with these tools, they may, in fact, make us better. And so some health systems, especially, where trainees are learning, are thinking about, well, maybe in the first year of training as residents, we don't let them use any AI tool because they have got to develop these skills in the first place. And then only turning on the availability of some of these AI tools when they're perhaps in their second year of residency. But I don't think that there is a standard yet, and different health systems have different tolerance for when they make these tools available.
When you started talking about the plane, it made me think of, if the AI makes the plane safer, I definitely want the AI helping the pilot fly it. But I also want that pilot to go in a simulator when I'm not on the plane and do some flights without any AI on a regular basis, just in case the co-pilot doesn't work out. One of the other areas in medical education, you and I both spent some time in this space. I was thinking recently about evidence-based guidelines, right? And the practice of care. And the fact that the longer we seem to go, the more guidelines people seem to come up with. And the guidelines change pretty frequently. And the volume of medical knowledge continues to just like mushroom cloud. It is just out to the point where I do not believe that anybody is consuming even a fraction of the amount of information and new data that's coming out. And so, in some ways, the best practices lag the knowledge. That may be okay because we want to harden the knowledge. But even when we get to the best practices groups, just thinking of all the medical societies are all publishing guidelines at different times, some of which conflict with each other. Many times we have multiple societies who feel that they have, authority over often the same area. Is there any thought about education and the hospital systems about their own protocols and best practice? I'm assuming a provider system has to decide based on their own clinical insights and their own clinical expertise, what they believe is the right standard of care for them to exercise in a hospital. Is that an opportunity for education as well?
Yeah, I think so. And you're right about the volume of medical knowledge. There's no way for any individual to stay on top of all of it. I'll say larger health systems benefit by having committees which are meant to try to stay on top of guidelines and decide what they're going to implement or things of that sort. But those are the exception to the rule. There are plenty of small health systems, rural health systems where those resources aren't available. And so can AI potentially help guide the clinician to the latest practice guidelines? Yes, absolutely. And in fact, I have a project right now where we're looking at trying to help physicians adhere to best practice guidelines, because again, there is the volume of information and knowledge is so massive, it's impossible for people to stay on top of.
That was actually where I was going in my head. I was wondering if you could look at the episode of care. So, and maybe I'm phrased the wrong way, but if you look at a patient's care journey, whether it be through one institution or one encounter or not, could you actually find all the places that care deviated from this, what's considered the best practice standard of care, and use that as a learning mechanism? And there's lots of reasons, right, why you don't do exactly the same thing. You know, my wife works in a hospital and she'll always tell me that, like, you have no idea what's going to happen next, right? I assume you have the same experience. And sometimes you have to call whatever you're going to do just based on whatever happens. And then you need to figure out how to, remedy the situation. Certainly that's individual, right, in the situation itself. But is that an idea of actually looking at overall quality and content of care and then creating, is that an education opportunity then?
Yes. So part of what I work on is called Diagnostic Excellence, and that's looking at, how can we help clinicians continuously improve in their diagnostic performance. And the analogy I think of is like, if you are a professional football player, you can bet that after last Sunday's game, you are reviewing the footage and learning from what you did well, what you didn't do well, to improve your next game. And you see that over and over again. You see it in almost every industry and not in healthcare. Why is that? Well, it's hard to know, especially for diagnosis. Like, did you get a diagnosis right or not? There isn't necessarily always a gold standard, but even when there isn't like a system in place. There aren't dashboards in place to say, hey, Dr. Rosner, you got, 84 of those diagnoses correct, but then there's 16 you didn't. And these are the ones that you need to learn from to get better. I'm actually working with several medical specialty societies right now that are actually building dashboards looking at clinician adherence to diagnostic practice guidelines. So what those mean is, like, if you're diagnosing X, Y, and Z, are you doing all the right steps necessary to get to the diagnosis? And the idea being, the physicians hopefully then learn from opportunities to get better as diagnosticians. It's called recalibrating. But one of the challenges in medicine is, if anybody ever comes up to me and says, hey, Dr. Rosner, do you remember that patient from 2 weeks ago? The moment they stop there, all of a sudden I'm like, oh no, did something go wrong? Did I do something wrong? So there's a culture in medicine of not wanting to be told that something didn't go right. And we need to really change that culture, because at the end of the day, clinicians are humans. And there was a major publication years ago called To Err is Human, and clinicians will err, but we have to learn from those errors. And so creating a better culture in medicine to say, here's learning opportunity, just like other industries, you want to learn from it so you get better. And then creating also space and time for clinicians to look at those errors. Right now, our time is filled with patient encounters, and there isn't time set aside to say, hey, you should look at your performance metrics so that you can learn how to get better.